Good morning, everyone. Are y'all ready to start? Do y'all have any questions for me before we get going? It's our last lecture. Cannot believe it. I know y'all are excited, but I'm going to be sad because I actually like y'all. Okay, y'all ready to get started? Okay, we're going to start with Jessie. Here's our case study. So Vicki Lane is a 26-year-old woman admitted last night to the ICU for toxic shock syndrome. She has diffuse red rash all over her upper body and complains of headaches and weakness. Assessment, her blood pressure is 100/60, her pulse is 142, respiratory rate is 22, temperature is 98.2. You notice a band of bruising around her right upper arm and some blood oozing from underneath the bandage of her right AC where morning labs were drawn. Her skin feels clammy and cool. So what is DIC? Anyone? Baby clots that are useless, bleeds easy, microclots. Okay, that's good. Yeah. So it's a coagulation disorder. So it's either widespread clotting of very small vessels, which that leads to really no help for you because you need a larger clot to be able to stop bleeding. Either that or it's the consumption of those clotting factors for some reason or another. And it can be life-threatening if you can't stop the bleeding because obviously they'll bleed out. So the clotting cascade. What's the clotting cascade? Yes, Catherine, in surgery it's bad. What is the clotting cascade? So it's triggered by some type of damage, so it's endothelial damage. And it causes the release of those factors, the tissue factors, into circulation. Then you have the inappropriate activation of the clotting cascade. So this extensive thrombin entering the circulation is overwhelming. Causes the anticoagulants to unrestricted clot formation. So those platelets clump together, causing those small blood vessel clotting. Somebody has their mic on. Causing that small blood vessel clotting. And that small blood vessel clotting can ultimately lead to organ damage. It just allows those areas to not be perfused. So it damages organs, it destroys those blood cells, and it depletes all the clotting factor that's circulating because it's taken up into those little microclots. And this will cause that widespread bleeding, both internally and externally. So what are the precipitating factors or the risk factors for DIC? What's some causes? Come on, you have to participate or I'm talking to myself. Sepsis, yes. What else? Trauma, yeah, trauma's a good one. Burns, that's right, we're studying burns today. Some cancers, that's right. So sepsis is a reason. It's actually the most common cause. And then you have those complications from pregnancy, like preeclampsia, any type of retained products, like any retained placental products. And then also HELLP syndrome. Cancers, y'all said trauma, burn injuries, which we'll talk about in a little while, There's infections, any type of infection, whether it's viral, fungal, bacterial, or a parasite can cause DIC. Overdoses, snake bites. It's actually the venom, obviously, not just the bite. Okay. So this is Vicky's Labs. That is her name, right? Yeah, Vicky. Making sure. And I hope y'all had time to print this off or at least have it somewhere you can look at it, because when I go to the next slide, we're going to ask some questions about the labs. So what is the clinical significance of her platelet levels in her coagulation studies? Is her PTT normal or PT normal? What are your normal PT levels? Our PT level is just a little high. So normal PT levels will be 11, depending on what resource you look at. It's around 11 to 13, 13 and a half. So she's not in DIC according to this, because in DIC it would be greater than greater than 12 and a half seconds. So I'm sorry. So greater than 12 and a half seconds would be DIC. Her PTT, the normal range is, what do y'all know that that's being? 25 to 35, that's right. So DIC would be greater, anything greater than 40. Hers is 41. Her fibrinogen, what are the normal fibrinogen? I believe Thomas is recording, Melina. 200 to 400. And hers is 741. So anything less than 100 would be DIC. When it falls below 10, a lot of bad things are about to happen there. You just really can't even have any clotting factors whatsoever at that point. So how does this clinically manifestate? So when we're talking about clinical manifestations, diagnostic labs are really the way that you are going to find the clinical manifestations of this. So you have an elevated PT or PTT, or they can both be elevated. Your platelet counts are low and dropping. Your fibrinogen levels are low. So 3 of these findings is highly suspicious for DIC, and 4 is an absolute diagnosis. Okay, so you either have low PT, PTT, or both of them. The platelet count's dropping, or it's low and dropping. You can watch Trending Labs to find that out. Fibrinogen, for some reason I can't even say that today. Fibrinogen levels are low. So 3 of those is suspected of DIC, and 4 of those is absolute diagnosis. So you asked Vicki about the bruising on her upper arm. What does that tell you? What's that lightly from? She's in the hospital. Yes, those are the 4, Alexei. So she's in the hospital. The bruising around the upper arm is usually from them taking a blood pressure on that arm. It shows that she's just going to bleed from even just slight trauma. So she's very at high risk for injury, especially falls or anything like that. She doesn't have very much clotting factor in her right now. So what other comorbidities should we be concerned about with someone who's in DIC or heading to DIC? It's one thing we already discussed this semester. Yeah, they have perfusion issues. Not so much a PE, because the clots aren't big enough to form a big enough clot. These are really, really micro clots. They're at risk for developing ARDS, and vice versa. People that have ARDS are at risk for developing DIC. And it's because the DIC obstructs that pulmonary microcirculation that causes the lungs to inflame and be irritated. What else would these patients be at risk for? Another comorbidity. We studied this earlier in the semester too. What about intracranial bleeding? And this is a big problem with them. Remember, this says comorbidities, okay? So comorbidity means something that's going to lead to death. So the ARDS and then intracranial bleeding. Intracranial bleeding because once you start bleeding in the brain from DIC, there's really no way to stop it. There's no way to tamponade that bleeding or to stop that bleeding in the brain. So what do you think the treatment is for DIC? The medical management of it? Okay, pretty much all of those are right. We'll go through them now, okay? So you're going to be looking to treat that abnormality or the underlying cause. If you don't treat the underlying cause or what's going on, it's just going to continue to persist. It's going to continue to happen. So if the platelets are low and there's bleeding, what are you going to transfuse? Platelets are low and they're bleeding. Yeah, we're going to give platelets. So if the platelets are low and they're bleeding, we're going to transfuse platelets. Okay. If they're PT and PTT are prolonged, what are we going to give? FFP. So that's that fresh frozen plasma. And I'm sure y'all know what it is, but it's the blood product. It's a blood product, and it's made from the fluid portion of the whole blood. So it's used to treat those conditions where there's low blood clotting factors. And then your fibrinogen levels are below 1. Even after you've given fresh frozen plasma, what are you going to do? Cryoprecipitate, or you call it cryo sometimes. Here, I'll spell it for you over here. Okay, it's called cryo. What do y'all know that as being? Cryo, so it's a frozen, it's frozen therapy. It's a frozen blood product. So it contains factor VIII, which is that anti-hemophilic factor. And then sometimes, this is not all the time, but sometimes they will give heparin. Why would you give heparin to someone who's unable to clot or is bleeding? What would be your hope giving that heparin? Yeah, for the microclots. So what you're hoping is that heparin's going to stop those microclots from forming and consuming up all your clotting resources. So if you bust up those microclots, maybe you can make a bigger clot somewhere else. Okay? So what are some of these nursing diagnoses? We already talked about risk for injury for her. What are some other ones? Tissue perfusion, that's right, ineffective tissue perfusion. Risk for bleeding. Ischemia, yes. About unimpaired gas exchange. We talked about the lung tissue being inflamed. Yes, risk of acute pain also. I think anytime someone's sick, there's that risk for anxiety. Okay? Okay, so interventions, what are we going to do here? You got to monitor frequently and closely these vital signs, including the pulse ox on these patients. Why are you wanting to do that? Obviously, you always need to know what their vital signs are, but why? What would be your real reason for doing that? What are you trying to look for early? Yeah, you want to look for those signs and symptoms of shock. Okay. You're gonna watch your INO. You don't want to fluid overload them. You're monitoring your stool and urine for blood. You're also going to watch those increasing signs of ICP. What are your increasing signs of ICP? LOC changes. That's right. What else? Yeah, you can have the pupillary changes. What about confusion, lethargy? Yeah, widening pulse pressure. There we go. Now you are talking. Good. Okay. You're also going to be monitoring for bleeding, and monitoring for bleeding is also going to be watching your stool and urine for blood, but you're also going to be following your labs to see what the trend is for your clotting factors and your platelets. You want to make those assessments and interventions that would target sites for end organ damage. So ischemia from those microthrombi and organ function diminishes, and that's going to cause that renal perfusion to decrease. What does that put you at risk for? Organ failure, but tubular necrosis also. That ischemia is going to cause the necrosis in the tubular area of the kidneys. What medications would you tell these patients to avoid? What are those ones that are going to cause decreased platelet aggregation? Can be some antibiotics, aspirin, NSAIDs. Good. You also, what are you going to keep them from bleeding rectally? You're not going to do any type of rectal probe. You're going to, sorry, I was reading the slide over there. You're going to monitor those areas from the bleeding. You want to avoid any type of IM inductions because you want to decrease that risk of the MI of bleeding intramuscularly. And if for a patient that is bleeding, you need to monitor the amount of external blood that's being released. So you need to monitor the number of dressings. You need to be documenting the percentage of blood that's on that dressing. So the percentage of saturation of that dressing. Is that dressing 5% saturated? Is it 90% saturated? All those things matter. And how long it took to saturate that dressing. Did it take 4 hours? Did it take 30 minutes? Those all tell you about bleeding. And it's definitely more of a descriptor than just saying moderately saturated. The dressing was moderately saturated. Don't say over how long, or moderate to you and moderate to me may be two different things. Anytime you suction, you want to assess the suction output to make sure there's not frank bleeding. And if you do have to suction, you need to use low pressure just to prevent that excessive trauma. Oral hygiene. What do we know about oral hygiene? What are some things you're going to do for this patient? You want to avoid some things. You want to avoid some of those, those lemon glycerin swabs you'll have, or any type of commercial mouthwash that's going to dry out the mucosa. And drying out the mucosa is going to cause them to have a breakdown and possible bleeding in their mouth and the oral area. You want to use just a sponge, a wet sponge, to clean out their mouth. And all those things for risk for skin integrity. So skin integrity is that ischemia and bleeding of the skin. So you want to make sure your skin's in integrity remains in contact. Obviously, those bony prominences you're going to have to watch and document. Skin folds. You need to make sure that you can identify those areas of breakdown quickly. And obviously intervene. Repositioning these patients and using a special type of mattress. I don't know if y'all have seen them use this before, but they'll put lamb's wool, it's that fluffy stuff, in between their fingers or toes or around their ears or underneath their neck if it's needed to keep that from breaking down. And then we talked earlier about fluid volume, and this goes with your INOs also. You want to make sure that you're not giving excessive blood or any type of factor components. So you really need to be watching for edema, any type of crackling in the lungs, which would be fluid, right? And you need to make sure that your intake is not greater than your output. Make sure you don't have those crackles in the lungs. So you need to be, they can definitely develop quickly, especially with fluid volume overload. You need to be assessing their breath sounds every 2 to 4 hours. And what's with the edema? Edema can also just be given from fluid, but what else is happening with the edema here? Where's some of that fluid coming from? Where's some of the fluid coming from? Edema can be caused by taking in too much fluid, but where is there another shift happening? You're having a shift. Remember we talked about albumin, what makes that barrier less easier for it to pass in and out of interstitial space. That's right. So your fluid may extend outside of the intravascular system and go into the interstitial space, which is that third spacing. And that's because of the change in the osmolarity of the blood in the outside space. Okay, so not all your edema will be intake of fluids. It could be from the shift of fluid. These patients can be given diuretics. And if needed, you can decrease their fluid volume. But there comes a time when you're giving. Why is it osmotic change? Just because of the components of what you're giving. If you're giving a bunch of blood products, you're changing the osmolarity of the blood, making it more permeable in or out. Remember we talked about albumin. If you're giving plasma, you're going to be giving some albumin. If you're giving a lot of fluids, you're diluting them out. It's the mix and match of whatever you're doing, but it is going to cause some shifts. So just know it's not just from giving them IV fluids. And also, you have to count your blood products as intake. And then there are ID coping mechanisms. What are some coping mechanisms for these patients? Obviously, explaining everything to them and the reason behind it, keep them updated. Anytime you have that decreased knowledge and that uncertainty, it will increase that anxiety. What about family support? How would you help the family during this time? How would you help the family? Information, keeping them informed, that's right. Yes, help them understand the disease, that's right. Listen to them. Also know what your support services are for them if they need to talk to someone, if they need assistance in any way. Know that your social work, that's your support system there, case management, social work. So let's go over our medical treatment again, because I really want you to have this part. What are you going to give if your platelets are low? Platelets are low and there's bleeding. What are you transfusing? That's right. If your PT and your PTT are prolonged, what are you going to give? That's right, FSP, that fresh frozen plasma. Your fibrinogen levels are low. What are you going to give? And you've already given FSP. You're going to give FSP first to them, and then what are you going to give? Cryo. That's right. What are you giving cryo? What does it have? How's cryo helping? Yeah, has clotting factor in it. That's right. And then you give heparin. Why would you give heparin? Not all the time, sometimes. That's right. Stop those microclots from eating up all the factor. That's right. Wowena, FFP is for which? So you're going to give your FFP for your PT and your PTT. And you're also going to give it for your fibrinogen levels. But when you give it for your fibrinogen levels, you have to, you're going to give FFP first. If that doesn't work, then you give cryo. So mainly with DIC is that you need to know how you're going, what your clinical manifestations would be. What are your labs going to look like? How many of them does it take? It takes 4. 3 is the probable diagnosis, and 4 is an absolute diagnosis. You're going to want to be able to control their bleeding and prevent bleeding. You're going to watch for those other things that can happen to them because of DIC, like the ARDS and the intracranial bleeding. And then what is that patient going to look like in the hospital? What you're going to be monitoring those vital signs. You're monitoring those INOs to make sure that they're not becoming fluid overloaded. Giving the diuretic if you need to get some fluid off of them. Know that the edema is not necessarily just because of giving them so much fluid. It's also because of that shift, that intracellular shift. You're watching the stool, the urine, the sputum if you're suctioning for blood, and monitoring those labs. Yeah, they'll be in the ICU. You'll manage some platelet issues and some clotting stuff on the floor and a regular floor, but once they get to where you have these 3 clotting factors that are off, or your PT, PTT, and your platelets are off, you'll definitely have them in ICU. Okay, so those are the important things to know about DIC and knowing how to manage that patient. Okay. Any questions about DIC? Okay. Go to thrombocytopenia. So what is that? What are your platelet levels? What should your platelet levels be? Yeah, 150 to 400. So they call thrombocytopenia anything less than 140,000. And there's some causes. You're either not making enough platelets, you're consuming them too quickly, or they're being destroyed too quickly. Sometimes they can be diluted out if you're adding products like plasma. You're not giving whole blood products. Anytime you're not giving whole blood products, you're at risk of diluting out your platelets. Okay, so some reasons decrease platelet production. What can cause that? Well, first of all, so decreased platelet production, when does it occur? What's going on? If something's happening with your bone marrow, right? So that occurs in the bone marrow. And you're right, yes, cancer, some medications like sulfas, methotrexate. Infections was what liver disease would fall under. So that chronic hepatitis would be under infection. We also have sepsis, TB, and viral infections that go under medications. What about aplastic anemia? Not chronic alcohol abuse. And radiation. So what are some things that increase platelet destruction? So the destruction is the mechanical destruction of the platelets. Lupus, yes. ITP, yes. What about antibodies? Okay, so what are some things that increase the consumption of platelets? What's causing those platelets to be used up? The TIC, that's right. What's the most common cause of thrombocytopenia? We just named it in those. It's that ITP, okay? So that's that immune thrombocytopenia. The old name for it was idiopathic thrombocytopenia. And this occurs, it's your immune system starts to destroy your platelet cells, it attacks it. So what are some of your causes? We talked about those antibodies. They attach to the platelets, and then your body destroys the platelet because it's carrying that antibody. So it's an immune response. It happens more frequently in children and women. And in children, the disease usually follows a viral infection. It can also be after a viral infection in adults, but it's more often in adults after some chronic long-term disease process. Pregnancy can cause it. Any immune disorder. So what's the medical management? In children, it usually goes away without treatment. Adults are a little different. What's something we do for adults? Yeah, you're going to treat the underlying cause, but what else are you going to do for adults? Well, if you give a platelet transfusion, what's going to happen is that you can give it if your platelets are critically low. But what you also have to remember is, yes, it's going to destroy those new platelets too. That antibody is going to attach on to that platelet, and your body's killing anything that has the antibody on it, right? So at first, you're going to want to give some type of anti-inflammatory steroid like prednisone. Yeah, you're going to give steroids. And why? Why does that help? You're going to suppress the immune system. And suppressing the immune system is going to slow that platelet destruction. Okay? So in some cases, you're going to surgically remove the spleen. That's going to increase your platelet count in about half of these patients. And then, as I said earlier, you will give platelets. They can be given if they're critically low, but it's usually a little bit ineffective. It's kind of a minor patch, really, but it tends to be ineffective because of the antibodies are going to bind back to those platelets, and the body's going to do the same thing. So if the disease process doesn't get better after you're giving prednisone, also give danazol. It's been shown to increase the platelet count in patients. Rachel, yes, you can give IVIG, but IVIG is extremely expensive. It's usually one of the last line. I mean, extremely expensive, like $30,000, $40,000 for a small bag. And danazol is attenuated androgen. Not ideal, but at times it have to be given. Yeah.
All right. Can you just spell the danazol?
Danazol.
Yeah. Sorry.
It's okay. And in some patients that have certain blood types, that anti-RH can be given. Rogam is one of them. Isabella, are you talking about the anti-RH? Okay, that's an immune response also. So it's you'll see pregnant women who are a positive blood type that are pregnant with a negative blood type, and vice versa. If you have any of those RH, if you have any of those RH positive people that end up with any type of RH negative exposure, you want to give that so the body doesn't start attacking those antigens, basically, and attacking your body. Okay, so that's when the RH therapy. And then those drugs that stimulate bone marrow function. You want to stimulate the bone marrow. What drugs are you going to use for that? Y'all know this. I've heard it before. You want to stimulate your bone marrow to produce more, not just platelets, but everything. What about Epigen? Y'all have heard of Epigen, right? Okay. Y'all are quiet today. And monoclonal antibodies can also be given, and I'm not even gonna say this because it's Hold on. I misspelled it. That is a monoclonal antibody. This is also that it's given. So your Epigen and your monoclonal antibodies are the ones that are going to increase platelets. Your anti-RH is going to keep your body from destroying more. Danazol is going to increase your platelet count. And IVIG is basically it's an immune factor, so it's going to, as we said, it's very expensive, but it's going to boost your immune system and cause your body not to fight against it. Those nursing diagnosis.
Ms. Waldrop,
Do you have your hand up? Yeah.
Yeah, I have a really quick question. I was reading in the Lippincott book that it says that treatment is initiated when platelets are less than 30,000. Would you agree with that, or do you have a different number?
I mean, you're not gonna address it first when they're 30,000, but some of the extreme measures, you're gonna start giving platelets early on when it starts dropping below 100, somewhere around there. But when it gets to 30,000, you're in crisis mode at that point. So that's when you're given all these other things.
Okay, and so then, yes, thrombocytopenia was considered anything less than 150,000. So for ITP, would that number be the same? Or does it just vary?
Yes. It can vary, but yes, that's the same number.
Okay.
Because it's the reason, it's still thrombocytopenia. It's the reason behind the thrombocytopenia.
Okay, yeah, that makes sense. Yes.
Yeah. Okay, so it's still the same thing, but this is the reason behind this, the ITP. So now we're working, to get those platelets up, and that's the medical management part of it. Your diagnosis we talked about for DIC also. So that increased risk of bleeding, that impaired tissue perfusion, the risk for injury, risk for infection. So what about nursing interventions? You got to prevent these falls, right? Because falls can lead to head trauma and obviously more bleeding that you're not going to be able to stop internally and externally. So you have your bleeding precautions. We talked about them a minute ago. You're checking your stool for blood. These patients can't be constipated. You don't want them having any straining. You're monitoring their INOs. Patients with ITP, medication, education about medication. ITP, they shouldn't take anything that has aspirin, ibuprofen, or warfarin in it. Those all interfere with the platelet function or blood clotting. So they can cause bleeding. And those patients that are on those corticosteroids, what are they at risk for? Infection, what else? Osteoporosis is what I was looking for. So long-term corticosteroids is osteoporosis. So they need to have that bone density test, and they need to be supplemented with calcium and vitamin D supplements. Now, the second type of thrombocytopenia is heparin-induced thrombocytopenia. So what is that? Heparin-induced, right? Why? What do I mean? Yes, hyper on blood glucose. Sorry, I didn't see that till now. So what happens in heparin-induced thrombocytopenia? Good. So the formation of antibodies against the heparin platelet complex. So when the heparin bonds onto a platelet, then your body has produced antibodies to any heparin platelet combination. Okay. There's some factors that affect this. It depends on the type of heparin that's used, how long they've been using the heparin. It's usually when it happens, someone that's been on heparin for longer than 4 days. And some surgeries appear to be risk factors, especially cardiopulmonary bypass. And then those bovine preparations of heparin, they're more likely to lead to this heparin-induced thrombocytopenia than other preparations. The ones that carry the lowest risk are the low molecular weight heparin. And it does not seem to matter what the route or the administration of it is. It doesn't seem to be a risk factor. Women are at greater risk. So what's a hallmark sign? Yes, low platelets, but when? Yes, that's right. So the decline in platelets usually happens around 5 to 10 days of platelet therapy. Of heparin therapy, sorry. So that's why you need to get a platelet count at the beginning of any heparin therapy, and it has to be monitored throughout therapy. The platelet count can drop up to 50% in 1 to 3 days.
Oh, that's sorry. Did you say Ashland or Ashton? Oh, okay. Sorry, I was like, oh, I remember Ashland. He was my preceptor there. It's like, hey. No. When I
So these platelets will fall under 50,000. And when it begins to fall, it's ideal to discontinue the heparin.
But this is actually like my and the whole detail dream job to start specifically in part like in
And those patients that are at risk, the ones that have thrombosis formations, so they're receiving heparin, obviously.
So why specifically? So as I said, I don't know if you guys saw my blog, is that I was one quick
So what lab are you going to monitor to detect that heparin-induced thrombocytopenia?
just about every healthcare facility, hospital, nursing home, compassion. And our clinical is kind of different.
Your platelets, but what else? Yeah, your
Yeah, we have a
PTT.
lot of, everyone there is and how the actual facility
Your PTT is going to tell you about what?
burn scale, things that I actually use in my job. It's just, I don't want to get hurt. Actually trust you.
Clotting time, that's right. So your platelet count and your PT are important, but your PTT is going to be one of the first things that's going to tell you about if their heparin-induced thrombocytopenia is starting. So how do you treat this? Obviously, we're going to stop the heparin as soon as possible. Then you're going to have to initiate those alternative means of anticoagulation. So if you have someone who is post-cardiac or someone who has DVTs, you still, yes, this was prolonged. So you're going to have to give other things to help them not clot. You can't just not give them anything, right? Especially stroke patients, things like that. Yes, that's right, Rachel. So Algadabin, it's an inhibitor of thrombonin. It's FDA approved as an anticoagulant, and it's used in the treatment of HIT. Can also use warfarin because it is an oral anticoagulant. And these patients, if they are at risk for, if they've had a thrombosis, they do need to continue this anticoagulant therapy for 3 to 6 months. Yes, Jessica?
Sorry, Ms. Walczak. Thank you, Christine. I heard that you don't initially use, or read that you don't initially use warfarin. Would you say that you use warfarin after the heparin-induced thrombocytopenia has been corrected?
Stabilized. Yeah, stabilized.
Okay.
That's right. You don't use it until you have a normal platelet count. So you would use warfarin once it's stabilized. So these patients also need to be aware that they can have this reactivation of this disorder if they're exposed to any heparin within the first 3 to 4 months after diagnosis of HIT. So within that first 3 to 4 months, if you do have to have any heparin, it can happen again. It's less likely after that time. It has been seen in patients, years later that it does happen. You have to have enough time for those antiplatelet antibodies to be removed from the circulation. And that will take, that 3 to 4 months for all of those antibodies to be out of your system. Yes, good to add to the allergy list. So the treatment of that is that you stop the heparin. You have to find some alternative means of that anticoagulation. Argatroban is a inhibitor of thrombin. It's FDA approved for HIT. That's right, and you add the allergy alert for the heparin because they've had a reaction to the heparin. But like I said, 3 to 4 months goes by, and all those antiplatelet antibodies are out of the system, the patient's system. They definitely have a decreased risk of ever having it again. It just takes time for them to be removed from the circulation. Okay. Any questions about idiopathic or heparin-induced thrombocytopenia? Your medicines and your your medicines and your interventions and your signs and symptoms are important. You need to be able to identify that this is happening to a patient. Like if you're given a scenario. Yes, y'all are smart. I feel like by the time you get to this point, y'all in some way have studied thrombocytopenia or clotting issues. So I kind of hope that it's a little bit of a review. Maybe not the exact medicines, but what you need to know about it. So let's see how smart y'all are on HELLP syndrome. Okay, so what is it? What does it stand for?
I'd like to give maybe 5, 7, 10 years around there.
Okay, we have the H. Give me an E. Elevated liver enzymes. What's my other E? I mean, my other L, sorry. Low platelets, that's right. So, hemolysis, so the breaking down those red blood cells, your elevated liver enzymes, and your low platelet count. Okay, so we know what it stands for. What is it? When does it happen? It happens during pregnancy. And it is a variant of preeclampsia, more severe preeclampsia. It usually happens in the 3rd trimester, or sometimes it happens right after birth. It is difficult to diagnose, especially if this patient has high blood pressure. Sometimes these symptoms can be mistaken for gastritis or disease, hepatitis, attacks, gallbladder disease.
I think that our brain is designed to.
And the risk factors. So it's unclear what actually causes HELLP syndrome. It is common in, we said it's a variant of preeclampsia. So women who have preeclampsia or some type of pregnancy-induced hypertension. It's also seen in women that do not have any blood pressure issues prior. There's a greater chance of reoccurrence if they've had help with a previous pregnancy.
So all I really expect is
most common in women over 35. Caucasian. And if they've had more than, if they've given birth more than 2 times, so 2 or greater times. So what are some of their physical signs and symptoms that they come in presenting as? Because they don't come in and say, I have HELLP syndrome. They come in, they sit down for an assessment, and they're like, oh, I have a headache. What else do they say?
It's not very common here.
What they have after they eat? Epigastric pain, right? So they'll have this nausea, vomiting, indigestion, this epigastric pain after they eat. And that's where they think it's misdiagnosed for having gallbladder disease, some type of acute hepatitis or gastritis going on. Is it tenderness in the abdominal area, especially in that right upper quadrant pain? Yes. They'll even have shoulder pain and pain when they do any type of deep breathing.
What do I currently do? I got to do it.
They'll have edema and swelling, which is going to cause that weight gain. And yes, just so they can have nausea with or without vomiting. They can start to have some bleeding issues and also vision changes. And what's the vision change from? What symptom already did we name? Yeah, their blood pressure. So you're looking for these signs of high blood pressure and protein in the urine. Those are the things that are going to zoom you in on that it's HELLP syndrome. So high blood pressure and protein in the urine. So what are the reasons most mothers become critically ill or die?
And what are the next steps in this process?
hemorrhage, yeah. Stroke / hemorrhage. And then their liver can also rupture. So liver rupture or stroke, which I put that into the hemorrhage category. Okay. So the severity of HELP, what's it measured by? What's the severity measured by?
So you asked me what my critical for long, 5, 7-ish years, and
Low platelets. So the severity is measured by the platelet count of the mother.
How long is it?
It's done in 3 classifications. I don't need you to memorize the classifications. I just need you to have heard them and know them. So classification under 50,000 platelets is severe. Class 2 is platelets between 50 and 100,000 is moderate. And class 3 are platelets between 100 and 150. Okay, that's mild. And what can be done to prevent HELP? Is there any way to prevent it?
Yeah.
There's no way to prevent it. But what's the best way to help avoid? What are some things you're going to do?
I'm already married. Those are kids on the way.
How are you going to avoid it?
I mean, let me find some wood to knock out real quick here.
Okay. So you want to be in the best physical shape before you're pregnant. You need to follow up on those regular prenatal visits. And prenatal visits include all the teaching and labs and things that need to go on there. Also, informing the healthcare provider of previous high-risk pregnancies or a family history of HELP. Also, educating them regarding the disease process itself or nutrition and what signs and symptoms to alert the healthcare provider to immediately. So what do you do for the baby? We talked about what you're going to do for the mom and what you're watching for in the mom. What do you do for the baby? What's your treatment for HELP syndrome if the infant is under 34 weeks gestation?
And I'm wondering, on the surgical side of things, there are most of your patients.
So under 34 weeks gestation, a term baby is 40 weeks, obviously. Babies under 35 weeks automatically go to the NICU. So babies under 34 weeks, you think about they're not necessarily, they're a 23, 24 weeker that's really not viable. There's the babies in between that are going to have the ICU care. So your goal with these patients is really bed rest for the mom. Y'all said corticosteroids or dexamethasone over there. What are you giving that for?
And one more is what is your health biggest challenge?
Maturity, right? It's helping those lungs of the babies to develop more rapidly. It's helping with surfactant production.
I may have, once or twice.
What are you giving to the mom when she starts seizing? Mag, that's right. Magnesium sulfate will be given to the mom when she seizes. And how does that magnesium sulfate affect the infant? The baby's still inside, remember? What's it causing that baby? What kind of depression? Mental depression?
I'm here.
Yeah, so what it causes is respiratory depression, a depression of the respiratory drive, which is the CNS. But the big thing with MAG and the newborn infant that they're delivered during this time, they really just have no effort. They have no drive to breathe. Okay, very common. These patients will also, if the baby is under 34 weeks, will also be transfused platelets if they get too low.
Oh, on Facebook.
Let's
Got
start
it.
with blood pressure medications to try to get her blood pressure under control.
Yes, that is me. Yeah, she's a little bit bigger. I can pull her over if you like. All right, one moment.
You continue to monitor the infant using
Where
the
you at, girl? Oh,
biophysical
come
tests,
here.
sonograms,
Come here.
and the fetal movement evaluations.
Sweet thing.
So the goal there under 34 weeks is to manage the symptoms of the mom and try to keep the baby inside. There is a time when it becomes, there's a time when the blood pressure can get so high that the baby's just not getting what it needs in utero anymore. And that's the decision when the child is taken out when they're younger than 34 weeks, that you can manage them better and it's healthier for them to be outside of that environment.
Right. But yeah, she's currently wearing a t-shirt.
What about over
She, like I
34
said, she
weeks?
has a bulge on her shoulder that she tries to look at.
So over 34 weeks or worsening HELLP syndrome. So worsening HELLP syndrome would be those babies that are under 34 weeks too, right? If the mom is worsened. So yeah, so you're going to want to deliver. It used to be automatic C-section for anybody that had signs of HELP. Now it's not an automatic reason. Insurance has gotten crazy on what they'll pay for as far as C-sections, but if it's severe enough, it will be C-section. They do not want them delivering vaginally. Why would they not want them delivering vaginally? You're going to bleed when they cut you in the stomach too, right? A lot of effort, that's right. A lot of effort. You're increasing those pressures whenever you bear down to try to push a child out. You're causing all kind of pressure accumulation. Okay? It's now recommended that they at least try, if their cervix is favorable, that they at least try a trial of labor. But 9 times out of 10, they do end up in a C-section. And the reason they try to avoid C-sections, although they're what end up usually being done, is because you do then have those clotting problems because you do have low platelets. And now you've just cut them across their abdomen into their uterus. So now you got to control the bleeding and get their platelets up. So for any infant that's over 34 weeks or the mom's HELLP syndrome is worsening, the treatment is to deliver the infant. So how does this HELLP syndrome affect the baby? What do they look like? They have high birth weight or low birth weight? Yeah, they usually have a low birth weight. And the statistics are if the baby is at least 2 pounds, they have the same survival of a healthy outcome of a non-HELP baby, the same size. If they're less than 2 pounds, they don't do very well. The stillbirth rate is higher. And most of the deaths that are attributed to HELLP syndrome are due to placental abruption, placental failure. What happens if the placenta fails? What do I mean by that? What does the placenta give the infant? Yep, that's right, O2 and perfusion. So technically, the technical term whenever the placenta fails, it's intrauterine asphyxia.
You're a good girl, Bella.
And these patients are also born extreme prematurity. And that's what most of the deaths are attributed to. So most of the deaths are attributed to abruption, that placenta failure, the intrauterine asphyxia, and extreme prematurity. And the complications of HELP, They can be life-threatening for both mom and baby. We just talked about placental abruption. This mom's can have pulmonary edema. The fluid builds up back in their lungs. These moms can go into DIC. They can have ARDS, or they can develop ARDS. They can have ruptured liver. They can go into acute renal failure. The infants can have respiratory distress syndrome. Intrauterine growth restriction. So the maternal mortality rate is about 1% with HELLP syndrome. The infant mortality rate is about 10 to 60%. That depends on their gestational age when they're born, the severity of the symptoms, and how quick they get treatment. So how is it diagnosed? It's kind of in the name. You need those liver enzymes, right? Because they're going to be elevated. You need your CC so you can see that platelet. You need your electrolytes to be able to establish renal function. Remember, one of the signs is going to be protein in the urine. And you also want to see your coagulation profile so you can start watching for DIC. And what's important for the assessment of mom? Blood pressure, yeah, what else? Their blood pressure is high. What else are they probably going to have? Edema, that's right. So you're going to be monitoring their weight. We talked about they could have respiratory failure. They could have fluid back up into their lungs. They have pulmonary edema. So you're going to be watching their pulmonary system. So you're looking for those any crackles in their lungs, diminished breath sounds, any decreased O2. And yeah, you're also going to be looking for those vision changes and headaches. Sometimes they'll often say, especially if HELLP is just starting, HELLP syndrome is just starting, they'll say something's just not right. I just don't feel right, because they really can't put their finger on what exactly is going on. Okay, so I have a case study here for this infant. So you have Jeanette King. She's 17 years old. She's 37 weeks pregnant. She presents to L&D triage with complaints of not feeling well. She has a headache, a stomach ache, and the doctor sent her to the hospital. You collect a urine sample and take Janet to her room. You attach monitors, ask Janet if she's having any contractions, and she states that she does not know because it's her first pregnancy. All she can tell you is that her upper right of her abdomen has been hurting since 1 a.m. It woke her up. It's a pain of 8 out of 10. Her vital signs: her blood pressure is 208 over 127. Her heart rate's 128. Respiratory rate's 29, and her temperature is 99.8. On her assessment, her legs have +2 pitting edema. Her urine has +4 protein. And there are no contractions on the monitor, but her cervix is closed. We've got some issues, huh? Okay, so here are her labs. So what diagnostic signs and symptoms are present for Janet? How is she presenting? Hypertension. Yep, she has right upper quadrant pain. She has edema. What else did she have? Yeah, she had protein in her urine. She's tachycardic. She had tachypnea. She's pretty close to having a fever. So what labs would you collect on the patient? So you want a urinalysis. In urinalysis, you're looking for protein in the urine. Your CDC, you're going to want, you're checking your platelet levels. Your chemistries are going to be checking those liver functions tests as AST, ALTs. Your PT and PTT will check the fibrinogen levels. So in HELP syndrome, that platelet count will fall. It can fall around 50% in the first 24 hours when the syndrome begins. What are some additional signs and symptoms of HELP syndrome? We talked about some of them earlier. So she will have that epigastric pain, that nausea and vomiting, that headache, that exhaustion. Yeah, that malaise, just that tired. Edema, she can have those visual changes. Hyperreflexia. Have seizures. Bruising or bleeding easy due to those low platelets. You can have decreased fetal activity. So what medications are likely to be ordered for her? How many weeks is she again? She's 37 weeks. Yeah, you're going to want her to get MAG. MAG's going to prevent those seizures. They'll usually get a bolus first to get a loading dose, and then they're put on an IV maintenance, a drip. Not necessarily a blood transfusion yet. So we're going to stop her from having seizures, and then this baby could possibly come. So what do you want to make sure you give this baby? It's going to do two things. That's right, dexamethasone. It's going to help with the fetal lung maturity, and it's going to also help reduce the liver damage in the mom. Yes, you can give a Laetolol or a beta blocker to control that blood pressure. And if those things don't work, then you will be delivering the infant. One of those absolute indicators for the delivery of the infant with HELP. You know, we talked about if the mom's getting worse, but what platelet count? So I have two things here. I have platelet count under 100,000. I have also seen 50 in places, but I'm going to go with 100,000 right now. You're also going to want to deliver them if their their hepatic or their renal function is getting worse. Persistent nausea and vomiting. Those infants over 38 weeks. If there's any type of fetal distress at this point. And if you suspect an abruption, is when the placenta comes off from the side of the uterus. That can happen a lot with high blood pressure because of the turbulence that's going on with the blood coming through. Some nursing intervention, nursing diagnosis, sorry. How about deficit of knowledge? Risk for bleeding, risk for falls. What else? I took the easy ones. No one. Risk for bleeding, risk for fetal demise. What about a risk for imbalance of fluid volume? Ineffective tissue perfusion. Acute pain. So for this patient, what outcomes would you want to see? You want to see this patient is verbalizing the need to be in a dark room and on bed rest. Dark room for less stimulus, bed rest so that she does not have any exertion whatsoever. Yeah, you're going to want to lower that blood pressure. You're going to want her pain to decrease to at least a 3 on a scale of 1 to 10, or 0 to 10, I should say. We don't see any spontaneous bleeding from her. And some of the interventions for Miss Janet here. We talked about the quiet dark room, bed rest, away from distraction, but some things you can do for pain control. Left lateral side. Guided imagery. If you give a sedative, what are you risk doing? Yeah, respiratory depression of the infant, right? In the real world, yes, you can give sedatives, and you do give Narcan. In this scenario, you do not, okay? And that's because of the respiratory depression in the infant. You're going to want to follow her daily I&Os. Those are some interventions for her. Frequent vital signs. And TED hose to control that edema, peripheral edema. Would you put an indwelling catheter in her for I&Os? Yes. How would you assess the abdomen? She's complaining of pain in the abdomen. Pain also comes from an abruption. It can also come from her liver. So what are you going to look for? Now, palpate her abdomen. You're going to want to look for uterine tone. Also, fetal activity or the position of the infant. And their room, I keep saying dark, quiet room, but they need to be near the nurse's station also. They need to be close to those emergency drugs and crash carts. The interventions would involve those seizure precautions. For these women that are on bed rest, you're going to be worried about her some type of thrombosis forming. How are you going to help that? Talked about TED hose. Those STD boots while they're in the bed. You do want her to be on a fetal monitor. So those fetal assessments would be those the non-stress test and the biophysical profile. They're looking for hypoxia and possible placental insufficiency in some way, though. Okay. A sono, I mean, the sono is going to tell you at this point the size of the baby. Sono is not as important as determining if the child is getting adequate perfusion from the placenta or adequate nutrients from the placenta. Make sure that they're not in any kind of fetal disease because of the mom's condition. Those are the things you're looking for in the fetus at this point. What other questions on health? What do you need to know when you're doing an assessment of a mom? What's important? That's the kind of stuff y'all really need to go over also. When do you deliver this child? What are the indications for delivering the child? What's important to know on a mom on an assessment? What are some of those things we've talked about? You're doing an incoming assessment on a mom. Her prenatal care, yeah. History of preeclampsia. Her symptoms, what her symptoms are now. So headaches, those vision changes. What's her blood pressure look like? How many births she's had, that's right. She has a history of health. How many births does it usually occur after? 2. Yeah, her lung sound, you're looking for that pulmonary edema. Her age, see if she's too old. I'm just kidding. Over 25, usually. I was 30 when I had my daughter, and I won't ever forget, she's my only child, but I won't ever forget going into my doctor's appointment after I turned 30, and they wrote in big letters across the top of my chart, advanced maternal age. I was like, oh no. You're looking for that age to see if they're at risk there. If the baby's under 34 weeks, you try to keep it in utero unless they're in distress. If it's over 34 weeks, or is in some type of distress, mom's situation is worsening, what are you going to do for that infant? UNICEF says 25 for the mom's age. Anything greater than 25 is where it's more common. And obviously, it's more common the older that you get within pregnancy. Yeah, you deliver the baby no matter what gestational age if they're in distress. What does MAG cause in an infant? Respiratory depression, that's right. What do you do if the mom has had too much MAG? What signs and symptoms are you going to see? Yeah, decreased deep tendon reflexes. If that mom's had too much MAG, she's going to show those decreased deep tendon reflexes. Yeah, decreased or non-existent, that's right. She won't so much show CNS depression. Well, if you've given her that much MAG, you're past looking for those deep tendon reflexes. But deep tendon reflexes would be one of the things that you would look for to know she's had too much MAG. Calcium gluconate is the antidote. And MAG's given for what? And how do you give it? IV drip, what do you do? I told you when I went over MAG. What did I say about MAG? It's given in a bolus and maintenance, that's right. What medicine do you give for infant lung maturity? Yeah, and it's important to get that dexamethasone as soon as you know that mom might possibly deliver, right? Because you don't want to say, well, I hope she doesn't deliver, because there's really no problem with giving that dexamethasone. I see moms in the hospital all the time that, she had her steroids, 48 hours ago. Well, at least the steroids are in her. I'd rather the steroids be in her for 24, 48 hours than her steroids be in her for 2 hours while she's going, for a section. So that doesn't really help any. So as soon as you think there could even be a possibility of to give those steroids. What does steroids do? Lung maturity, but what are they also helping? It's also helping the mom to reduce liver damage, but what else is it helping in those lungs? Yes, on decreasing liver damage on the mom. Very good. What else is it doing in the infant? Maturing those lungs. What else? Yeah, surfactant. What does surfactant do? Keeps the lungs from collapsing. Yeah, helps the alveoli stay open. Yeah, surfactant's kind of like dish soap. It's that type of consistency, and it keeps the lungs from basically collapsing all the way down. And every time those lungs collapse all the way down and they have to open all the way back up, their lungs are sticky if they don't have surfactant, and it shreds the lung. And shredding that lung tissue and that alveoli, that causes lung damage. Okay, so they already have immature lungs coming out, and then if you don't have enough surfactant in there, they're causing even more lung damage at that point. What are some of the complications from HELLP syndrome? Very good. Liver rupture, DIC, ARDS, pulmonary edema. What else? Y'all are on a roll. Keep going. What's a big one? For baby and mom. Placental abruption. That's right. Okay. I'm just making sure that's all I want y'all to know. What labs are you following on this patient? Patient being mom at this point. Liver enzymes. What else? PT, PTT, the clotting profile. Okay. All right, I'm good. Are y'all good? Catherine, you're not good?
What was it that you said was an indication to deliver the baby? It was 100,000 or was it 100? Was it less
I'll have a
than
break
that?
real quick. Let's do 5 minutes because then we have to get to burn. It is a lot of information, but it becomes repetitive at the end, which is it's good. It helps drill it in y'all's head. Okay, 5 minutes.
Could you
Be
hear
back
me?
at 12:32.
Can you hear me?
Okay, hurry.
Miss Raljak? Miss Raljak? Oh. Well, dang.
I can't hear you, Catherine, if you were talking at any point during that. Or I can't hear anyone, whether it was Catherine or not. What was it that indicates delivery? Less than 100. Some books say less than 50, but less than 100, and any type of distress. So those are absolute indicators for delivery. So the platelet count less than 100, your renal or hepatic function worsening, your persistent headache, that persistent nausea and vomiting, any type of suspected abruption. If their gestational age is over 35 weeks, any type of growth restriction or distress. Okay?
You don't really want to, I don't think. There's a little dust storm for you. But it's really pretty. I mean, look at some of these. See, baby, you don't really want to, I don't think. I fucking love the country out here. I just hate that it takes so long to get to work. So, that's my only thing that I'll ever be upset about. That's why I was like, singer's not bad, but that's not bad to go with my work. Your work, on the other hand, you know, you've always, I felt, well, you've driven from out there off 380, so it's not like you don't know what a long drive work is, too. So,
I'm back if anybody has questions while we're sitting here. I'm pretty sure it's 70, but I'll have to look again. I didn't pay attention, honestly, when I looked at it. I'll think of it this way, 80, they're worth less per question, so you can miss more and still pass. Is that positive? Positive thinking? See? Silver lining. Okay, Burns, you ready? Okay. What disruptions do burns cause in the body? What do they do? How does it mess your body up? Yeah, you lose fluid, so your electrolytes become imbalanced. Perfusion, immunity for infection, sensory, and thermoregulation. It also increases that need for nutrition for the body to repair itself. What are the types of What are the different ways you can get burned? Thermal, chemical. What else? Electrical. What else? One more. What about smoke inhalation? Okay, so the ways are thermal, chemical, smoke inhalation, and electrical. What about thermal burns? It's the most common type of burn. How does it occur? Thermal. What's it mean? Heat. So scalding, so hot water, contact with a hot object, flame, flash. What about chemical burns? So chemical burns are from that alkaline or acidic or type of organic compound. Alkaline burns are the worst because it's not as ready to neutralize by the body acid. So the body comes to its defense and is able to neutralize some of those acid burns before it can cause too much damage, trying to limit the amount of tissue injury that goes on. But it can't neutralize. Sorry, I think my mic cut out. It can't neutralize the other ones. Okay, and then smoke inhalation. How do you get smoke inhalation burns? Yes, that's an organic compound. Mm-hmm. Oh, wow. Okay, so smoke inhalation burns. How do you get them? Okay, smoke inhalation. So, inhalation of hot air or some type of noxious chemical will cause that damage to the respiratory tract. Usually, if you're going to suspect someone of having a smoke inhalation injury, they're usually going to have burns also to the head or the neck, chest. These burns usually in enclosed areas. They happen in enclosed areas. Also, you're going to suspect that they have an inhalation burn if they have singed nasal hair, hoarseness in their voice, coughing, sore throat, any type of black carbon in their sputum, or airway redness. Sometimes that'd be hard to see. And those are major predictors of mortality of burns in those patients. Any of the patients that have head, neck, chest, or face burns, they need to be given 100% oxygen. And you'll need to be frequently reassessing their respiratory. Some of those patients will have upper airway injuries, not from the hot air, steam, or smoke. It actually burns the mucosal, oropharynx, and the larynx. They can have blistering and edema. And edema is what to be assessed frequently because the respiratory status will change with the swelling and the blistering in their oropharynx or their larynx area. Because that edema will cause obstruction. And obstruction will eventually lead to respiratory failure, right? Well, you might have gotten me on that one. I'm not sure if it's the most deadly. I think a thermal burn, it can actually burn you up. The smoke inhalation burn, it can cause the most complications, that's for sure. And it's most deadly because of respiratory complications. I'll actually try to find out what's the most deadly type. Because now I'm curious.
Yeah.
just want to tell you, I'm a good director. That robot.
Someone else's mic's on. I honestly, I can't hear the mic, so I don't know.
You and I.
Oh,
I
yeah.
sent her a text. I can't do it today. Need to postpone this till next week.
Hater. Oh, I knew you were a good director. I never thought so, or thought otherwise.
Yes, I can see Catherine's mic's on. Hold on. I think I can mute. Okay, there. I didn't know I could mute y'all. Okay, anyway. So those are the upper airway injuries from, you have that redness, blistering, and edema is going to lead to, or can lead to obstruction, and that's going to lead to that respiratory failure. Okay. Those patients sometimes need to be intubated if it becomes an emergent situation due to the edema. Now, lower airway injury, that is usually caused by inhaling the toxic fumes. It can also lead to edema and respiratory distress. What's different here is the edema can sometimes not be seen for the first 12 to 24 hours after the injury. So what else happens? What other complication happens with smoke inhalation burns? We already talked about that. What else? Smoke inhalation burns. What else can they get? About carbon monoxide poisoning. There you go. All those answers are right. I was looking for carbon monoxide poisoning because it's something that they will get in a burn. But they'll also tear their lungs up with all the things that y'all just said there too. Okay. So carbon monoxide is another condition that can happen with smoke inhalation burns. So obviously that carbon monoxide, it displaces that oxygen from a hemoglobin on the molecule side of it, causing that hypoxia. So these patients are going to have a red cherry skin. They'll have headaches, nausea, vomiting, changes in LOC, and sometimes they're unconscious. So what's the headaches caused by? If you take an oxygen molecule, low O2, that's right. So the headaches and that change, the LOC change, is due to hypoxia. I had to look at that for a minute, Alina. Yes, yes, yeah. Low O2 is the reason why, which would be a high CO2. Okay. Then we have our electrical burns. So these occur from that heat generated from an intense electrical current. The severity depends on the voltage, the tissue resistance, the pathway that the current took, how much surface area, and how long it lasted. So the duration of that flow or that electrocution. So what would be, there's something called the iceberg effect. What is that? Can only see a little, yeah. So it's not being able to see what's underneath the surface. So the injury may look minor on the outside, but extensive damage can be done on the inside. Yeah, that's good. Y'all know that. Okay, so it can also cause cardiac and kidney problems. Why is this? What's released from an injured cell? Potassium. What else is released? Potassium is right. That's one of them I'm looking for. I'm looking for one more too. What's released for an injured cell? You'll know this because we studied it with MIs. Myoglobin. So myoglobin and potassium are released from these injured cells, and those will lead to cardiac and kidney problems. So all burn patients need to have an EKG and continuous cardiac monitoring. So this myoglobin release. It travels to the kidneys and it can cause blockages leading to the acute tubular necrosis and renal failure. You should also suspect these patients of having a cervical injury. So electricity can cause severe muscle contractions and so strong that it can actually break the bones while the electrocution is going on. So you need to make sure you assume they all have a cervical injury, so you need to treat them with C-spine. And very young children are at risk, or at greater risk for an electrical burn. Think about why that is. Yes, they get into everything. They'll stick anything in any hole, right? So you have an electrical socket and they stick stuff in there, or their fascination with wall sockets and electrical cords. Yeah, curiosity, okay? So very young children, they're at greater risk for electrical burns. What's the classification of burns? What determines the severity of this burn? The severity of the burn will be determined by the depth of the burn, the extent of the burn, where it's located, and what your risk factors are. Who's at a greater risk for burns? Elderly. So older adults and children. Patients with diabetes, and why would that be? Neuropathy. Adults are also slower healers. If you have any type of pre-existing cardiac, respiratory, or renal disease, can cause a poor poor healing, slower healing. Okay, so the depth of the burn, the superficial burn. What does it involve? Which areas of the skin or layers does it involve? Epidermis. It involves the epidermis. The skin's usually red, dry, has some edema. Yes, Jessica.
I am scared, Ms. Roljak, because you said that the epidermis is.
Jessica, you have a question?
Yes, can you hear me? Oh my God, is it your computer? Because I don't know if you can hear me.
I can't hear you if you're talking. No, like, I can't hear you.
Is your computer low-key muted? Because that happened to me yesterday.
I can still hear me, right?
Oh,
Let me see if I can fix this.
I'm scared.
Okay, now talk.
Hello.
Still can't hear you.
Of course, this happens in our last class. Of course.
Type it over to the side. Christine, you can't hear anyone? Somebody talk so I can see if I can hear y'all now. That's really weird.
Can you hear this?
Hello.
Okay, type the question, Justin, and I'll answer. Well, only the epidermis is involved in superficial. Partial thickness is more the dermis involved. And I'll go back and double check on that. I'll email y'all today. Okay, but for superficial burns, it's only the epidermis involved. The skin is red, dry, and has edema. It usually heals within 1 week without treatment. What's an example of a superficial burn? I don't know why I'm asking y'all a question if you can't. Okay, sunburn, that's right. So a sunburn or radiation exposure, something like that. Okay, then you have your partial thickness burns. So the dermis is involved, and it can include the entire dermis. So it's broken up into 2 types also. So you have the superficial partial thickness burn, and it's described by the skin being painful, red, moist, glistening, and blisters form. A deep partial thickness burn extends further into the dermis, and that would look like pale, waxy. It can be moist or dry, but they're large, flat blisters. You can have some contractions and scarring. So for partial thickness burns, you can have superficial and deep partial thickness burns, okay? And then you have full thickness burns. So the epidermis and the dermis is involved. It can also involve subcutaneous tissue, connective tissue, muscle, and if it's bad enough, it can involve the bone. And these are caused when you're exposed for a prolonged amount of time to the source, the burn source. These do require skin grafts to heal. And these burns will be dry, waxy, they're leathery and white, usually hard, and they're not painful. Why do you think they're not painful? Yeah, nerves are burnt. Nerves are fried. Okay, the extent of the burn. We're going to go over a couple of commonly used guides to determine total body surface area. The first one is this Lunn-Browder chart, and you'll see how it's broken up into sections, and the sections are a percentage. So this one's used most for an after burn. This is this is used to determine the total body surface area of the burn. Okay. This one's usually used on after admission to the burn unit. It gives a more accurate estimate of the extent of the burn. The next one we are going to look at, you don't have to know, you don't have to memorize these. You need to have a general idea of what the percentages are. Okay, you do have some burn calculations on the test, and they give you, yes, I'm going to the rule of 9, but they give you the amount of body surface that is affected already in the question. Okay, then you have the rule of 9s, and this is a method. It's a rapid method. It's used as an estimation. It's usually used in pre-hospital or emergent care before you enter the ER or the burn center. Okay. A little bit of a problem with it is it's not very accurate for someone who is short or obese or very thin. Okay. So you have the body. It's divided into 11 sections, and all of them are worth 9%. Okay. So you have your head, arms, chest, abdomen. Okay. So it makes 99. That's why it's called the rule of 9. And then you have the American Burn Association. Pretty much close to the same thing. This is also used to decide whether it's classified as minor, moderate, or major burns. And which one of the burn types are not going to be used? You're not going to calculate the body surface area. Sorry, I said types, that's not what I meant. Damage types. Yeah, the superficial burns, right? Superficial burns is like a sunburn, okay? Why is it important to know the total body surface area of a burn? Fluid replacement, that's right. So you wouldn't do fluid replacement on a sunburn. I mean, you probably should do some fluid replacement, but not like we're talking about. Okay. So risk factors here. We talked about age already. So the young and the elderly at highest risk. Careless smoking, smoking in bed, or things like that. Intoxication. Physical and mental disabilities. What are some of those physical and mental disabilities that would affect? We talked about diabetes with neuropathy, Alzheimer's, depression. So any of those that cause problems and make them be careless or unaware of their surroundings in some way. Water scalding is also a risk factor. When do you think water scalding is mostly seen? Baby, that's right. So you'll see this in child abuse a lot. When I was working, scalding, so like hot water, like burns almost, water burns. So when I was working in the ER, I saw this more than one time, which is so sad. But these infants would come in, and from about their belly button down, they would be red, scalded, and above them would have nothing. You know, it'd just be normal pink tissue, skin. And the parents would dip them in like a hot bathtub to try to make them stop crying. And they would be scalded basically from their belly button down. And that's a common, unfortunately, is a common form of child abuse. So no, water scalding can make you think child abuse. Whenever you're doing assessment. Exactly. How would it make them stop crying? Just like how would shaken baby syndrome? How would shaken a baby make them stop crying? I think it's frustration on the parent's part. I guess I really don't know. And then the high risk behaviors and high risk jobs. So a line worker would be a high risk job. Right? Someone who deals with fire all the time would be a high risk job. A firefighter, fireman. And then there's clinical manifestations of multi-system effects. We have all kinds of changes because of burns. It can result from mass infection. You have those fluid and electrolyte imbalances. It's called hypothermia. If it's inhaled, a burn, it can cause respiratory dysrhythmias and vascular collapse. For those superficial burns, you have localized pain and redness without blisters with superficial. You can also have chills and headache and some edema if the case is severe. And then you have superficial partial thickness. These burns will develop blisters within minutes of the burn. It can be mild to moderate edema with it, and they will have pain. Deep partial thickness burns, those are going to appear that that pale waxy. They can be moist or dry. They will have blisters. They can also have some contractures or scarring that may occur. You'll have the decreased capillary refill in those areas, and they'll start to have that decreased sensation. Your full thickness burns, those are the ones that are going to be white and waxy dry. They're leathery, hard. They don't form blisters, and there's really usually no pain because of those nerve fibers being burned. We talked about acute tuberculosis earlier, and that it's caused by that myoglobin release from the injured tissues. And your cardiovascular problems, it's the same thing. It's from the damaged, injured tissues and carry the potassium being released into the bloodstream. Severe edema. This is within the first 24 hours that you have the severe edema. What happens to the capillaries? What causes the severe edema? Yeah, leakage. So they become very permeable, those capillaries. That's right, increased permeability. So they become very permeable, and that allows the fluid to shift out of the vessels into the tissue. And these patients also have a hypermetabolic state, which means they need so much more. They need like 1.5 to 2 times because of the burns. You talking about the increased capillary permeability? Yes, because of the burns. And their hypermetabolic state, they need 1.5 to 2 times. They're 1.5 to 2 times the basal metabolic rate has increased because of the burn. So their body's wanting to take in more nutrition, so they usually need around 6,000 calories a day. And of course, this depends on their age, size, and the severity of the burn. But they need those calories to heal and to maintain. We have these phases of burn management. So, emergent recessive phase. Which part is that? When does it start and when does it end? Okay, so this emergent recessive phase begins at the site of the injury, so on site of injury, through fluid resuscitation. And it includes that pre-hospital management and all the emergency care. So some of the pre-hospital management that would go on would be, pre-hospital would be on the site, right? So you're going to remove them from the burn source. Obviously, we're always assessing vital signs, so that respiratory system, cardiac, fluid. Rescuer needs to make sure that they are protected and don't become involved in the incident. With electrical burns, you need to make sure you turn the power off before touching the patient. They are still live. Live as in charged, I mean. With chemical burns on these patients, you need to remove the clothing, brush solid particles off the skin the best you can, do some type of water lavage, because this chemical burn can continue to burn and damage the tissues for up to 72 hours. Thermal burns, you're going to do clean, cool tap water on a dampened cloth. A large thermal burn, you're going to go with that ABC. You're going to want to wipe the, wrap the area in clean, dry blanket, and remove the burn clothing if it's not stuck to the body. If it's stuck to the body, you need to leave it. Through all these, you're monitoring the vital signs, their level of consciousness, their airway, breathing, circulation. Just a dry cotton blanket. I mean, you wouldn't want anything plastic on them, but just a dry blanket. You're also going to watch their temperature regulation, their thermoregulation. Children will become chilled very easily, and so will infants. They're not able to maintain their body temperature. Now, in the emergent resuscitative phase, not the pre-hospital phase, same thing. Now you're in the emergency room. You need a history. You need to find out from whoever brought them in, so EMS or whoever brought them in, whoever was on scene, of what was done prior. And let me go back. The history of that I'm talking about is not, yes, that's where I'm going. So the history that I'm talking about is not history like their health history. It's the history of the burn. So when did it occur? The death, the extent of the burn injury, what type of burn it was. You also need to know if they're on any medications. And what treatment was done before they arrived at the hospital. What do you think the greatest risk or greatest threat to these patients are in this first emergent phase? Hypovolemia. So hypovolemic shock, right? Because they're going to have this massive fluid shift out of the vessels into the this capillary area. It's going to cause that edema, low blood pressure, and elevated heart rate. The heart rate's trying to get that pressure up. This is when we talked about the potassium will be released into the bloodstream because of the damage. And that blood flow decreases to the kidneys and the acute tubular necrosis because of the myoglobin release. Airway management is very important during this time for ongoing fluid assessment. What do you want to put in them when they get to the hospital? Arcade ringers is usually your choice. 2 large bore needles, definitely. And really, the fluid replacement is going to depend on the age, any pre-existing conditions, the severity of the burn. So I talked about burn calculations a minute ago, and this is how you're going to figure out your burn calculation. Don't freak out. It's not as bad as it looks. And I also have a handout that I'm going to email y'all that has several burn calculations on it, and then you can just email it back and I'll tell you if it's right or not. Not required, just helpful. So for the fluid replacement, the Parkland formula, which is what is usually used, it's 4 mLs of fluid times the body weight in kilograms times the percentage of the total body surface area burned. Now, the percentage you don't turn into a decimal, okay? And that will equal the total 24-hour fluid requirement. The next one is the American Burn Association. And this is for flamed or scalding, okay? Adult will be, it tells you which one to use. It tells you right in the question. What I want you to remember is a child is 3 mLs for a flame or scald on the American Burn, and the adult is 2 mLs. If it asks you to use the Parkland formula, it's 4 mLs, and the rest of the formula is the same after that, okay? And electrical burns are 4 mLs. Okay, the Parkland formula is anything is 4 mLs. The American Burn Academy is flame or scald. For adult is 2, a child is 3 mLs, and electrical burn is 4. And I have all these on that page that I'm going to send out to you. So what you do is thought I had a, I must have it. I do. I have it in the, what do you call it? The case study where we'll work one out. Okay. So the thing to remember about fluid replacement, half of it is given over the first 8 hours and the other half over the remaining 16 hours. So we talked about that fluid replacement goes over 24 hours, right? So the first half of the fluids is given over 8 hours. And the other half of the fluids is given over 16 hours. That makes sense? And the time of this, you don't start the 8 hours of whenever they get to the facility. You start the 8 hours from when the burn happens. So if it takes them an hour to get to the facility, now you have 7 hours to get that fluid in them. Okay, if it takes them 30 minutes to get to the facility, you have 7 hours, 30 minutes to get the fluid in them. Does that make sense? It'll be important on your calculations. And Parkland is the most common use. Do you have questions about this? We have one to do in our case study that'll break it down for you. I remember if you're talking, I can't hear you.
Can y'all hear me? Okay. I don't know what happened. It just froze. Okay, so what do we need to learn for the exam? You need to learn these formulas. Okay? And we'll go over one in the case study. So this acute phase, when does the acute phase begin? So we talked about the resuscitative or the emergent resuscitative phase begins at the onset of the injury and ends with fluid resuscitation. When does the acute phase begin? The emergent, beginning of diuresis. The emergent ends with fluid resuscitation. So that includes the fluid resuscitation. Okay. The acute phase is when the fluid shifts back into the vessels, the swelling decreases, and the diuresis begins. Okay. So the fluid begins to shift back into the vessels, the swelling decreases, and diuresis begins. So if the patient has full thickness burns, this is the time you're looking at this. These patients will need a skin graft. The debridement will need to take place at this time to remove any damaged tissues. This also promotes wound healing. What would you give them before doing any type of debridement? Yeah, you're going to pre-medicate them. So you need to give them pain meds, but it needs to be pre-medicated before you start doing debridement. Remember, debridement is pulling a gauze or something of that type off the top of a wound. So they need to be pre-medicated. The wounds will also be cleansed. You can also use an antibiotic ointment during this time. Sometimes the wounds are left open, and then other times they will be closed depending on what stage of healing they're in. Important for you to know that you should always, as a nurse, wear a gown, gloves, and mask. You're protecting that patient from an infection. An infection is that major cause of death for these patients. So you don't want any sick visitors or caregivers, meticulous hand washing. And then you have your rehab. rehabilitative phase, and that is where you're preventing those contractures and scarring from happening. This patient starts to resume roles back, their life roles, and they can do range of motion exercises. So on your burn assessment, we talked about briefly a second ago, you want the time of the injury, you want the cause of the injury, you want what treatment occurred prior to arriving in the ER or burn center, their age, their body weight. So nursing interventions during the emergent phase, airway we talked about. So these patients with burns to the face, neck, and upper body, you're going to be concerned about their airway, so you need to be monitoring their airway. They may need to be intubated. If they're not intubated, they need 100% oxygen or humidified oxygen. For fluid resuscitation, you're going to have those two large IVs started. You're going to have to do one of your formulas, usually the Parkland formula, to determine the amount of fluid to be given. You're going to be monitoring during this time. Yes.
Can you hear me now?
If you had a question, I think you may have to type it. Okay. I don't see anything coming up, but if something comes up, I'll answer it. During the time you're doing fluid resuscitation, you're definitely monitoring their blood pressure and edema, and you're assessing for shock, any signs of hypovolemic shock. Wound care during this time. There's times that the wound care is delayed until the patient is stable, so their airway is patent, their fluids have been started, and there's adequate circulation established. We talked about pre-medicating prior to cleansing the wounds or doing any type of debridement. Making sure that you have a gown, gloves, and mask on. Sterility has to be maintained when you're doing this to decrease the risk of infection. When you have wounds of the eyes, like damage to the eyes, you want to use a sterile saline or sterile water to cleanse and prevent any type of corneal drying out. Burns of the lips, you're going to wipe the burn area on the lips with soaked saline gauze. Apply antibiotic ointment and perform oral care. Any type of damage to the nose, burns to the nose, you're going to make sure you don't have anything cause any type of pressure on that nose area. In your drug therapy, like we talked about before, you're going to have to give them sedatives prior to debridement and as they need for pain. It's also important to make sure that they've had a tetanus shot. We talked about them using antibiotic ointments. They'll usually only use systemic agents if there's some type of sepsis that's happened. And nutritional therapy is secondary to fluid replacement, so they're going to begin the fluid replacement first before nutritional therapy. And then after that, it needs to be started right away. Nutrition, we know, promotes wound healing. And remember, these patients are in a hypermetabolic state, so they need double the calories they would usually get. In your acute phase, monitoring, you're going to be monitoring the INOs. Make sure the bowel sounds return during this phase. Make sure they haven't developed any type of ileus. continue with your pain management, not page management. This is a time when you can start introducing different type of pain management techniques too, like stress reduction, relaxation, and evaluate how those pain management is effective or not. Wound care. Still sterile, washing the hands, wearing a gown, glove, mask while the wounds are open. Decreases their risk of infection. No sick people visiting. Nutrition therapy is the same also. You know, the adequate nutrition, you're monitoring their weight and their labs, making sure that you don't need to be giving any extra or taking away. And then your rehab process. When does this process begin? So this rehab process begins at the time the patient's wounds are covered with skin or they're healed, and the patient's able to resume the level of self-care activity. Okay. Anna Nelson is an 18-year-old woman directly admitted to the burn ICU after being caught in a trailer fire at 10 a.m. today. She has burns over 60% of her body's surface area. The burns are on her hands and arms are pale, waxy in appearance, and have no blisters. The burns on her chest, anterior legs, face, and neck are pale and moist with some large fluid-filled blisters. She has a brashy cough, sounds hoarse when she speaks. She weighs 110 pounds and is 5'4". Her vital signs: blood pressure is 98/35, heart rate's 147, respiratory rate's 43, O2 sat's 91, and her temperature is 96.7. She has a 20-gauge saline lock in her left forearm. Hold on, where are your labs at? Okay, I'll tell you what the creatinine is then. Her creatinine is high. It's 2.5. So why do you think her creatinine is high? Tissue destruction. So that release of the myoglobin, right? So what are the severity of her burn injuries? How do they describe her burns? Blistering. So where does that put us automatically? Yeah, 2nd degree, and you're right, deep partial thickness. Sheets of blisters, basically, is how they described it. And then what are the stages of burn management? We just talked about those. So that emergent recessive phase, acute phase, and the rehab phase. So Anna was asleep when her trailer caught fire and had to fight her way through the flames. What assessment findings indicate possible complications from being trapped inside a burning structure? Hoarseness, yep, brassy cough. What about her respiratory rate? Her respiratory rate of 43, that's tachypnic, right? And her O2 sat, right, her O2 sat was low. So that indicates that respiratory tract involvement. Burns on her chest. So what interventions would you plan for her? Yeah, airway. You want to optimize that gas exchange. So what kind of oxygen will she get? 100% what? 100% humidified oxygen, right? You got to keep it moist. You want to do those deep breathing and coughing exercises. You need to help mobilize that secretion. And you need to watch to make sure you don't have to intubate this patient at the bedside. So stage the burn she received. So the burns on her head, or hands, sorry, her hands, arms are pale, waxy in appearance with no blistering. What are these? pale waxy in appearance with no blistering. 3rd degree, right? So that's that 3rd degree full thickness. The burns on her chest, anterior legs, neck, and face are pale, moist, with some large fluid-filled blisters present. What is this? Second degree. So that's that deep partial thickness burn. So 2nd degree. Okay, the burns on Anna's arms are circumferential. What does that mean? And what are the implications? If it goes the whole circumference of the arm, yeah, they go all the way around. Well, what happens when your burns go all the way around? What does your skin do as you move? Your skin stretches as you move, right? Tight, right? So if you compartment syndrome, that's right. So if you have these burn all the way around your arm, as your edema starts or your healing begins, it's not going to be able to move. So you are going to have that compartment syndrome. So what do you do for that compartment syndrome? The biggest problem with this is swelling. It'll decrease that. It'll compress those tissues and blood vessels, prevent that blood flow to the hand. So what are you going to do? You're going to do what's called an escharotomy.
Lecture, and I have like.
So that damaged
5 to
tissue,
10 minutes
you're
before I
going
need
to
to
go in
leave.
and make these parallel and vertical incisions in the arm so that
Thank you.
it can move, it has mobility instead of this
How many?
tight, hard
Sorry, baby.
surface all the way around. So you have to go in and basically do these parallel incisions. It's called escharotomy, so that you don't have compartmentalization syndrome. So what stage of burn care is Anna in?
I know, that's our goal. I'm just saying, don't be upset. Either way, you're getting a raise. Okay.
Yeah, emergent. She was burned today, right? So what are your current priorities and interventions right now? She's in the emergent phase, so what's one of the main things you're doing? You're going to fluid resuscitate, right?
But yeah, my
Fluid
interview went
resuscitate.
really well.
You're going to keep that airway open.
It was actually, so normally she said, normally you do an
Tetanus shot?
interview with like a manager and like a
Monitoring urine
director
output.
and like a peer group interview. So she said, instead, because of COVID, they're doing it all at once. They're all sitting here in an office on speakerphone, basically.
Make sure you're gown, gloved, masked whenever you're messing with the burns.
Yeah. Yeah, I think
Gotta keep monitoring that core body temperature.
Especially given the fact, so they were, they
They
said
keep
they had
the
already
room
looked
warm.
me up on Facebook. They're like, your dog looks like exactly like my dog. I was like, oh, wait, what?
And
I was
monitor
like,
for that
oh,
inadequate
Facebook, got
hydration.
it.
So what's that going to look like?
And then I was
What's
like,
hypovolemia
well,
look like?
she's sitting here if you want me to go get her. And they're like, yeah, sure. No, I didn't do that. I told her that's why she's wearing a t-shirt.
Hypovolemia, they
I
do
put
low
the
urine
strips
output.
on, I covered it with Coban.
Yeah, that can lead to shock.
That'll help. She's now bent in some
What
very
else?
strange
Restlessness.
shape.
They could be disoriented because of that. Good.
Busted. Again.
Okay. So we need to give her fluid, right? So we're going to use the Parkland formula. You're going to give the first half over 8 hours, the second half over 16 hours.
Yeah, he's on that, and they said.
Okay, so the Parkland formula is 4 milliliters
Issue was, and they said staffing. They said
times
they're
the
looking
kilograms
probably
of body weight
said
times
like
the total
4
body
to 5
surface.
candidates,
So
or
she
maybe
was
more.
4 mLs
How many are they
times,
doing?
she's 50 kilos
And
because
there's-
she's
they're
110
interviewing
pounds.
22 people. I saw that.
And then 60% of her
Said they'll
body
decide what
surface
they
area.
want today
Right?
or
So that makes
tomorrow.
12,000 mLs over
And then I
24
should
hours.
hear back.
You have to divide that in half.
Contacting People who get selected.
So that's
early next
6,000,
week.
right? So 6,000 goes in over the first 8 hours.
I really
And
hope I got it.
6,000
I told
goes
them
in
I was
over the
very
next
clear.
16 hours.
They asked me, like, how do you feel about night
Okay.
shift? And I
So
was
if you
like,
break 16
not
into 8
ideal,
hours, it's 750
but,
mLs an
you know,
hour for the first 8 hours.
I'll-
And the remaining 16 hours is 375 milliliters per hour.
Grab that. Ooh, I should wash my jacket. It's been a couple months since I've washed my Columbia. I wish I could send you
Right.
a video.
So if you noticed in the tablespoons, I know what you meant. If you notice in the problem, it told you what her surface area burn was.
Alexa, living room light 100%.
Back in the beginning, it said 60% of her burns. And that's how it will be on your test. It'll give you whatever you need to know, and then it will say however much percentage of total body surface area is affected, okay?
But you can
So you understand this on the Parkland formula? If you can understand on the Parkland formula, you can understand it on the other ones. You just have to remember
really well.
when you use the other ones.
They're all chuckling and blah blah blah, and I think I did it.
Pause what?
Like, I don't want to be.
So 4 mLs,
Might be like one person. I saw a name on the list of.
okay,
the-
6,000 for the other 8
the
hours.
one.
So remember I told you half
So.
of the volume that you calculate, so half of the 12,000
I mean,
goes
and I won't
over
say, like,
24
this is
hours,
like-
right? So,
this is the
sorry, the whole total
unit
goes over
I
24 hours.
absolutely want.
Half
But
of this goes over 8 hours. Half of
I'll
this
be
goes
honest,
over 16 hours.
Yeah, I would love to work.
Okay, it's
here.
still half of
Work
it,
anywhere I
just
wanna work.
different hours.
My goal is to get into acute care.
Okay? Is everybody good on that? So
It's just spooky now.
your factors that would be changing in this is if it was an electrical burn.
Have anything bad on your Facebook?
Yeah, I have.
Okay, Christine.
Very.
If you look, see your Parkland formula is 4 milliliters times the kilograms times total body surface area. Okay? So underneath it is the problem. 4 milliliters
Facebook.
times, we know her kilograms are 50 because she was 110 pounds. So you have to convert that to kilograms. And then the next number is 60, which was her
Yeah.
total body surface area burned,
I
the
don't think
percent,
there's anything
okay?
too bad on my
Then you
Instagram.
multiply
Give me an
4
address, you
times
know,
5
Spain,
times
me and
60,
you.
and you get 12,000 mLs. Okay?
You make me
So that's
see
how
the
much you have to
faces,
give over
that's about
24
it.
hours. Now, you give half of that, so you have to divide 12,000 by 2, which is 6,000.
Yeah.
Half of that is
Just
given
make
over the
faces.
first 8 hours.
Like, what the hell did you do? My dog.
Okay? Divide that by 8. That's 750
I don't know
mLs an hour.
where, like, what direction
And the
these are
other
coming from,
6,000, half of
honestly.
it, is given over 16 hours.
Don't know how to do
Divide that by
like
16. It gives you 357 mLs an hour. Is that better?
Barely didn't get it. Ooh. That was yelly.
Yes, because you will have to say how many mLs per hour will
We
be
had our
given.
green light, we were already like through the like double green lanes on each like crossing road through, and the car like in front of the.
Okay, so the reason why I gave you the mLs per hour is because the question could ask you, how many mLs per hour would it be the first 8 hours?
A little bit, like you ran red.
Yeesh.
Okay, so when you multiply 4 times 50 times 60, you get 1,200 mLs, and that's your amount over 24 hours. Okay, now half of that, so divide it by 2 is 6,000. Half of that over the first 8 hours, and the other half over the 16 hours.
It's fine. I was like, man, it's like warm in my car.
Okay? If it doesn't make sense or you need extra help with the math, I can do another session for that. When I have a setup where I can write on the top of it for you, on the screen for you, okay?
What time do you work till 7?
I work until I'm done, or 6-ish or 7-ish. There's no, it's.
Yes,
it's
depending on
fuzzy.
what the question asks you. Christine says, so the formula helps us solve for the 24 hours. Then we have to figure out how much for 8 hours and 16 hours. Right. So it depends on what the question asks you. If the question asks you, what's the total volume for 24 hours? Then this answer is 12,000, right? If the question asks you, how much volume do you give in the first 8 hours? Well, that answer is 6,000.
Where are you?
You know, if it asks you, how many mLs are given an hour for the last 16 hours? That's 375 mLs. There's a lot of answers in that one problem there. So it depends on what the question's asking for.
Addison is
Does that
open
make
now.
sense? Okay.
Yeah, what time's your two patients?
Like I said, if it doesn't, just reach out to me by email, and then I can do a time when it's just
Call it a day after that.
whoever, and I can just write on the board for you here. Okay?
Dang.
Okay. So she survived the emergent phase and entered the acute phase. What'll let us know that she's made this transition, and what are your goals? So what do we say starts the acute phase? Yeah, diuresis, right? So the fluid begins to move third space back into the bloodstream. Her kidneys are filtering and excreting, so she's diuresing. And then what interventions are we going to be? looking for in this phase?
Not if there's nothing to do.
Still the same ones, that infection control,
I mean, you're also different in that, like,
your
they
wound
have
care
it clean,
needs to be
do that,
masked,
do that.
gown and gloves, your pre-medicating
You, like,
before,
don't have patience.
your range of motion, nutrition.
Yeah, that sounds like a good idea.
How did they fluid replace that before IVs? Yeah, fluid
I would be
replacement will be
washing
IVs.
dishes, but then we couldn't hear each other.
And you're still watching that respiratory response. That's right. So
Huh?
before we had IVs, how did they fluid? Like historical? Okay, like historical.
Oh.
I don't know. I mean, there's a lot of things that they just had to let people just die. I don't know. I really don't know how they did it other than that. They're probably just deemed not savable. And they just went into hypothermic shock.
They need to make another Nailed It holiday episode.
Okay. So when we begin to feed her,
We have our.
and what?
Yeah, I saw that. I called them. I was
It's
gonna
like
ask
any
about
surgery
what's the price on
or
a
anything like that,
12
you're going to feed her
monthly. So
when
they
her
have,
bowel
like,
cells
7,
return.
11, 14.
Now, what kind of
or
diet does she
18.
need?
I'm like, well, what do I didn't want to hear?
High calorie, high protein, high carb, right?
It increases the
And you may have to
price by, like,
supplement through the NG
$26.
tube as needed. Like they can't just eat all those calories on their own. You may have to
Yeah.
give them more through the NG tube.
You want what?
So what interventions will you
I'm sorry, I
need to
missed
move
everything
her
you
from
said.
the acute phase to the rehabilitative phase? Remember, burns are covering 60% of her body, and she has some full thickness burns. So what happens? Full thickness burns.
Hello?
Remember we said this.
And not big ball, I don't really like.
Yeah, graft. She's gonna need skin grafts
Yeah.
for thickness burns.
Under one, so it'd be like, the first floor available.
Yeah, moving sucks.
Yeah, but now like our.
She wants to know when she's going to be discharged from the hospital. What's the best way to plan this for her?
Like, I don't think you and I can listen to those.
Obviously, discharge
Yeah, we
planning
definitely
always
get
begins on the day of admission. But she'll leave when most of her wounds are healed.
I'm down to not move.
And when else?
So I'm okay with not moving.
We'll just stay on the first floor.
We can ask. We can always ask. Yeah. But I know I don't think there's any open ones on our courtyard.
That one.
Hold on, read this, Selena.
I have no idea. Yeah, we can always ask. Private yard, yeah, pretty damn nice.
So did they give them fluids back then or no? Because they thought they were dying of toxins. I mean, before they thought they were dying of toxins.
Scrubby, brush.
Yeah, just do or die, right? Okay, so you're going to start yeah, they didn't know, right? They're going to start the discharge planning on the day of admission. So whenever her wounds are mostly healed and she's able to do
Lecture end now?
her ADLs, right? Is whenever she will be able to go.
You okay? Yeah, you breathing pretty hard.
And appropriate nursing interventions, we've been over these a bunch of times in this. So
You got the
you're going to make sure
Band-Aid,
you're
power
assessing
toxins,
respiratory and all
the
vital
second
signs,
one.
but respiratory also for the rate, make sure there's no crackles, your level of consciousness.
I always
breath
ask how were they,
sounds.
you tell me the numbers. And you always know that when I ask how were they, I
Patient
mean
needs to have
how
coughing
were
and
they.
deep breathing, exercises.
Good.
You're going to monitor those sputum characteristics.
You're right. It's a stupid question because you're teaching, so it's always great.
Make sure you're following your peripheral pulses.
Right?
Notify the physician if there's any changes in pulses, capillary refill,
Alright,
or
I need
pain.
to start getting my shit for work because I need to
You're given this
start
pain
going to
meds
work.
as needed and pre-medicate before bathing, dressing changes, or any major procedures.
I wish I could set this to like stop recording at this time. I think technically I can if I
Need to
set
maintain
it
a
to do that
thermal
like at the
environment.
beginning. You know?
You need to make sure that when they're ready or performing those passive range of motions, that keeps them from getting contractures.
We just need some mascara.
And eyeliner and blush and highlighter and low lighter.
Splints, yes, you need
And-
splints.
some fake lashes, and
Use splints for the alignment.
what other things exist?
Okay.
Yeah, you don't contour
That's it on burns. I will send out
because you don't need to. So that's pretty cool.
that problem list that has the different problems of burns for y'all to practice. And you don't have to do it, but there are some burn calculations on your test.
Like basic mascara.
Oh yeah, raising the bar. I'll get those out to you.
Really good mascara.
I'll get it out to you tomorrow. Both of them, and I'll put some questions in prep you.
It's like a really good one.
All the same, right?
No, I'm not even close.
Bella, let's go out and put
Okay, if y'all don't have anything else for me,
further back.
y'all can go. I really appreciate y'all. Y'all been a great class.
Here's the real angle. I don't really.
Let me know if you need anything while y'all are studying. Thank y'all. I really have enjoyed y'all. Y'all been a great class. I'm glad y'all learned something.
Moved your head right when I was starting to get it.
And reach out to me and let me know whenever y'all pass your NCLEX.
Okay?
I always like to know who's going to be taking care of me out there.
No, we don't get any dogs on this.
Okay. Good luck. Reach out to me if you need anything.
Actually, yes.
Always, Diane.
Push. Better, sir. Bellaroni. Let's go. What? Yeah, I know what you meant. I will not have time to do that today until I get home.